which is on basics on eplet mismatch, amino acid mismatch, and PIRCHE-II score. For this, I'd like to invite our chairpersons, Dr. T. Raviraju, Chief Consultant Nephrology, Apollo Hospital, Visakhapatnam, Dr. R. Vijay Kumar, former Professor and HOD Nephrology, Stanley Medical College, Chief Nephrologist, Bilroth Hospitals, and Dr. Dr. Indranil Ghosh, and who is a Senior Advisor of Nephrology Command Hospital, Lucknow.
Yeah, good morning, everybody, for this today morning's session on eplet mismatch. It'll be my pleasant duty to introduce Dr. Massimo Mangiola from the United States, who will be speaking on basics on eplet mismatch, amino acid mismatch, and the PIRCHE-II score. Dr. Mangiola is Clinical Associate Professor at the Department of Pathology at NYU, and he has got an extensive research and published various research papers on transplant immunology, and he will be telling us and guiding us through the latest on the PIRCHE-II and the eplet mismatch, which will help us in deciding a better transplant care and avoiding of the de novo DSA. Dr. Massimo, please.
Hi, can you hear me?
Yeah, you can be heard.
Yes,
yes, okay. You can see my screen as well. All right, thank you so much. I want to thank the organizing committee for giving me the opportunity to discuss with you today a way to redesign the way we do HLA compatibility. And through this presentation, I hope to show you how our molecular compatibility, so if we change the way we do HLA match, or HLA matching these days, can change the landscape of compatibility and of course improve outcome, which is the focus of our interest. Just a quick conflict of interest, a member of the National Kidney Registry and Medical Board, and I will mention it here in this presentation. So I feel that we all would agree that there are some critical problems to solve when we're talking about kidney and transplant patients that are waiting for kidney transplant, and it's given by the shortage of organs. So whenever we do a transplant, we need to optimize the transplant. And so there are a few aspects that are really important. One has always been important to us is how can we reduce rejection? And as you can see from this graph, since 1965, we've been pretty good at coming out with a lot of ways to improve the 1-year acute rejection. But I think we can agree that in the last 5 years, I think we reached some sort of plateau where we can't push this curve any lower, despite all the drugs that we come out with that can contain the immune system. Another problem is how can you improve the longevity of the transplant? Of course, we don't want our patient to come back in the least in a short amount of time. And as you can see here, about for disease donors and live donors throughout the stratas, those are UNOS data, we have done a decent job in improving the long-term graft survival. But the question is, what can we do? Is there anything that we can do to fill this gap and improve this long-term survival even more so than we have done so far? And of course, another critical problem is how can we safely lower immune suppression? And immune suppression has done wonders, as you can see, as you saw from the first slide. But it doesn't come without any price. As you can see here from the cumulative incidence of primary cancers, there is a lot of problems that in a long-term use of immune suppression. So the question that has come up recently is like, how can we solve these critical problems? How can we improve the outcome of our transplants? And I feel that to understand in my opinion, the most logical approach to improving the long-term and hopefully lower immune suppression is to go back to the cell biology and to the origin. And the mechanism of post-transplant allosensitization that you see right here in the top left corner of the screen are well known, but the one mechanism that is the most intense, but because of duration, because of intensity, is the indirect pathway presentation. This is where the recipient antigen-presenting cells presents to the host, to the patient CD4 cells, peptide from non-self peptide from the HLA antigen of the graft. And if the CD4 are activated by this process, they can proliferate and then activate a CD4 and activate a B cell, and then you have cellular and humoral rejection. So this is the leading mechanism of allosensitization post-transplant. And the key element of this sensitization pathway is this immunological synapse here, where antigen-presenting cells are loading in their HLA molecule a non-self donor-derived peptide from the HLA of the graft. And the key element in this synapse, of course, is the HLA molecule and the polymorphism of this HLA molecule, which will dictate which peptide can be loaded, can be restricted in the HLA. And of course, the peptide that is restricted in the HLA that is seen by the T cell receptor and eventually activate the T cell. But interestingly, in transplantation, both of these events depend strictly from the polymorphism and from the difference that exists between the HLA antigen of patient and donor. In fact, the peptide, the patient class 1, class 2 molecules will dictate which peptide can be presented and be restricted and then presented to the CD4 T cells. And the molecular difference between the class 1 and class 2 HLA molecules between patient and donors will dictate which peptide, which donor-derived peptide can be seen as non-self by the patient immune system. So you can see that if we want to relook at how we compare and what type of degree of compatibility we assign to a patient and a donor, perhaps comparing the differences in their molecules as opposed to the nomenclature, the HLA nomenclature, their number, is probably the best approach in this sense. And we have several tools in our hands that can allow us to determine the level of mismatch between patient and donor, the level of the B cell receptor, and other tools that will allow us to determine the amount of peptides that are mismatched between patient and donor. So at this point, I want to give you a brief introduction of these tools that are in our disposal for molecular mismatch between patient and donor. So the HLA Matchmaker is a molecular mismatch prediction tool where the HLA molecules between patient and donor is not looked based on their HLA number, but they're compared based on differences in polymorphic patches across the entire structure, some of which are immunogenic. And what you do with this algorithm is that you plug in the HLA genotype, allele level HLA genotype of patient and donor, and then the algorithm is going to determine which one of these immunologically relevant patch, these HLA eplets, are shared between patient and donor, and which one are exclusively present in the donor HLA molecules. For these donor-derived HLA eplets, the algorithm is going to return to you a list of all the eplets, total, antibody verified, and others. And what we learned so far is that the higher the number the higher the molecular mismatch at the level of the aplets, the more likely that the patient is going to experience rejection and de novo DSAs. And the literature has plenty of example. I want to show you this one that perhaps is one of the most known from the Nickerson group, where you can clearly see that above a certain number of mismatch at DR and DQ, the probability of de novo DSA at DR and DQ is significantly greater for this group of patients that are transplanted with these donors. And again, this is one of many papers that proves that the greater is the mismatch at the RNDQ at the level of the aplets, the higher the probability of forming de novo DSA and rejection. The HLA-EMMA is a prediction tool where, again, the HLA molecules are not looked at based on their nomenclature number, but based on the amount of mismatched amino acids between patient and donor. Also here you will enter your HLA alleles for patient and donor. And what the algorithm is going to do is to look at the shared amino acids and then determine the solvent accessible mismatched amino acid. Those are amino acids that are readily available for contact with the antibody. And for these solvent accessible amino acid, the algorithm is going to return a number for each allele. And also in this case, what we know is that the higher the number of mismatched solvent amino acid, the more likely is that the patient is going to experience rejection. And also here, the literature is quite extensive. And this is one of the examples for the DQ, where you can see that when a certain level of DQ mismatch for this solvent accessible amino acid, the more likely is that the patient will experience de novo DSA at the DQ level. And so also here, this is reinforcing the fact that the more mismatches we have at the class 2 molecules, especially the RNDQ, the more likely is that our immune system is going to respond with an adaptive immunity against the organ. Another very, very good, interesting algorithm is the PIRCHE. And the PIRCHE algorithm predicts the amount of non-self HLA peptides that can be derived from the organ, and they are indirectly presented to the CD4. So this algorithm specifically studies the mechanism of indirect allopresentation and makes a prediction of how strong this allo-sensitization is going to be. Also in this case, you enter in the algorithm the allele level HLA of patient and donor. And what the algorithm is going to do is going to predict all the possible peptides that can be derived by the donor HLA molecule. So those are all the mismatched peptide between patient and donor. But then it layers up something very interesting, which is which one of all the potential peptides that can be presented, can be derived from the donor, can actually be presented. So what the algorithm do, the algorithm consider the patient HLA and consider which one of all the peptides can actually be loaded in the class 2 of the HLA of the patient and presented to their own CD4 cells. Because of course you can imagine the situation where many peptides can be derived by certain differences between patient and donor, but only few of them can actually be physically loaded in the antigen pep binding site in the class 2 molecules of the patient. Now for the peptides, they can actually physically be present, restricted in the HLA and presented to the CD4. The algorithm will return a score where the peptides derived from class 1, A, B, C, and DR and DQ are presented by the DR and DQ of the patient. And what we know also in this case is the higher the amount of non-self HLA peptide that can be presented, the more likely is that the patient will experience rejection. And also here, the literature has plenty of papers. So I'm just going to show you this for simplicity, where the T-cell alloreactivity that was tested by ELISpot is compared to the estimation of graft-free survival, the no DSA-free survival by PIRCHE, and you can see that the two curves are incredibly similar to each other. So PIRCHE is very good also at predicting the probability of forming de novo DSA in long-term graft rejection. So we have on hand at least 3 tools that can allow us to calculate the molecular differences between patient and donor and make a prediction when we have a transplant as to whether the patient might experience de novo DSA and rejection. So how do we harvest this information with the, of course, the hope to engineer transplants that are a low risk by any of these tools so that we reduce the probability of de novo DSA and we improve the long-term graft survival. And the question on hand is, are we ready to do something like this these days? So the first thing that we need to do to move from the HLA compatibility as we have done so far is to try to remember and accept that compatibility is not binomial. Compatibility doesn't come as a yes or no, but it's rather a degree. And these tools, this is what they do. They show us the degree of compatibility between two individuals. And I'm bringing this one haplotype within the binomial compatibility as we have used it so far, just because I want to take a brief parenthesis here and show you that even related donors, those are data from the National Kidney Registry, so they are parent related to child or child to parent. Only 25% actually low or zero DRDQ eplet mismatch. The vast majority of related donors that have been transplanted in the US are actually moderate risk, and 13% is high risk. So the condition of being one haplotype match doesn't mean that you're automatically molecularly better than the unrelated donor out there. That's actually not a thing. So what we need to do, we need to first, in our mind, move from what we have done up until now and say, is the patient matched, yes or no, to how dissimilar they are, how many differences exist between the HLA of patient and the HLA of donor. Because the greater the differences that in the donor side, the more likely is that the patient is gonna see, the immune system of the patient is going to see this difference and act upon these differences. But how do we go from there to there? That's what has been a little bit the slow starting of this new wave of compatibility. And I want to give you a direction that is much more clear than all these wavy lines right here. And forgive me for this silly example, but if I would ask you which one of these 3 devices can actually start a fire first, I think we can agree that the flamethrower is the one that is more likely to start a fire. And so if this is indeed a statement that I can do, I wanna ask you, if I show you 4 donors, they are otherwise medically and surgically similar, but they're different by an increased amount of molecular mismatch at the DRDQ from 0 to 35. And if I ask you now at this point, which one of these donors is more likely to start an immunological fire, I think also here we would agree that this donor right here is less likely and this donor right here is more likely. So to me, the approach of moving from the compatibility as we have done it so far, which was do they match or not, and by simply comparing an HLA nomenclature number, which by the way has no correlation with the molecular differences. In other words, the number of the nomenclature are based on when the antigen or the alleles were discovered. So A1 and A2 are no more similar than A1 and A80. There is absolutely no correlation. Actually, in a way, A1 and A80 are more similar than A1 and A2. So to me, this is a logical approach, given the possibility of choosing between donors. We should aim to find the donor that is less likely to start an immunological fire, even if the patient is not compliant. So how do we actually apply this in real life, right? And of course, the most obvious way that we had was to tap in the incompatible donors. So for incompatible donors, you clearly can start a chain. You can create a chain where you also put into the algorithm the lowering of the molecular mismatch between DR and DQ, and this is being done for a few years now here in the US, and we actually at NYU try to do this internally whenever we can as well. And yes, of course, creates an additional calculation complexity, and of course the molecular mismatch, the lowering the mismatches at the RNDQ has not the intent of taking away everything that we have done when considering a donor in the medical clearance and surgical clearance of the donor. But when you have the possibility, of course, of choosing multiple donors for one patient, our goal is always to try to reduce the amount of molecular mismatch at the RNDQ. And of course, for this reason, because you have these small cohort, internally, this process can be a little bit tricky. The next choice, the obvious next choice, is still in the living donation. But this is for compatible donors. And one thing that we have been advocating here at NYU is the decoupling of even compatible donors if we know that there are good chances for the patient to get a better molecular mismatch if they decouple and they enter into a chain. But of course, also in this case, each and every one of our centers don't have a sufficient volume to give the large molecular diversity that will allow us to find a better molecular donor for our patient. So what we have done, we have teamed up with the National Kidney Registry here, which is the leading organization for living donors transplants in the US. We created these Kidney for Life initiatives where all patients and donors are HLA genotype by NGS, so it's NGS-based HLA genotype. And for any potential donors, now we can calculate the level of molecular mismatch at the RNDQ, so that when I have my match one for my patient, I can see the potential donors with low molecular mismatch, those with moderate, and those with high. So after us, clearing the donors for their surgical and clinical qualification for donation, then we go through the task of trying to find the lowest mismatch. So for all the donors in KR now, we can see physically before we accept the offer, but which one is the level of mismatch at the R and the Q, so that when the clinical team has a set of donors that are otherwise transplantable, we try to choose the one that have the lowest molecular mismatch, which should improve the outcome for our patients. So if you ask me whether redesigning HLA compatibility is actually a thing that can be done, I would say, look, we do have the tools that allow us to do the type of assessment that is more immunologically refined, and then we have at least we have the tools to engineer transplants to be low molecular mismatch. So the future direction, of course, is to continue facilitate and engineer this low or zero DRDQ molecular mismatch and collect all the information that we need to do prospective studies so that we can show that actually the performance of these engineered transplants is at least non-inferior to the average transplant out there. But of course, the expectation is that they will perform better, especially in the long term. We continuously educate, and we are preparing education materials for patient and donors to try to explain the benefits of molecular matching as compared to the traditional ABDR antigen match, and what is the long-term implication of switching from one method to the other. This allows us to have a discussion even with compatible pairs with the intent of decoupling, where we assess, which is of course the first thing that we do, the HLA compatibility at time of visits. And when we know that the compatibility is not the most favorable, we try to explain the benefit of molecular matching and the benefit of decoupling and entering a chain exchange with the scope of improving the compatibility. Now, of course, something that dear to me is to, once we have all this information, once we know that the system is working, how can we find a way to assign priority to this molecular mismatch? This is going to be a very tough one, because of course, probably that you can imagine there is no like a rigid score where you can say below this number you get this much point, above the number. But certainly we need to find a way to assign priority, because there are certain patients that are incredibly different, incredibly hard to match, even at the molecular, especially the molecular mismatch. You can imagine certain patients that perhaps are homozygote at the RNDQ, where they are very highly sensitized. So when they happen to encounter a low eplet mismatch donor, how can we give priority to that match run other than others? And with this, I want to thank you for your attention. I'm ready to take any question that you might have. Thank you.
Yeah, thank you very much, Mashami, for your excellent lecture.
Thank you.
And sparing your time or your probably your evenings, and today is the morning. So good morning from India. Let me
Good morning.
Let me know that you have told us about several matchings about matchmakers, EMA and PIRCHE. So should we go all three all together, or which one is the best? because practically in day-to-day life, it is not possible in the day-to-day care, particularly in country like India, where we can go for all the matchings for particularly where the living donor transplantation is predominantly happening here. So
Yeah.
which one is the best, and should we go really for all three, or one? Which one is the best?
They all have demonstrated to be able to predict de novo DSA and rejection. So you can use any of the three, and you would be able to identify which one is the better match for your patient. If you wanna, they all have extensive publication. They have been extensively studied, and they can actually work very well. They don't necessarily correlate, but that's actually something good that I'm looking into. But yeah, you can use any of them.
I'm Dr. George Abraham from Chennai.
Very nice meeting you.
Yeah, thank you for that excellent talk. I just want to ask you, there is always a conflict between the immunologist and the transplant surgeons and the physicians. I recall an incident over a decade ago in a meeting in Germany between the transplant surgeon who is asking the immunologist, if it is your son or daughter, will you wait too long to get the excellent match before you transplant or before they perish? Now, I am bringing it to the Indian scenario where we are in the progress of doing a lot of deceased donor transplant. We don't have a central lab to look at all these mismatches. What we basically do across the country is a CDC cross match rather than doing an HLA, even a simple basic HLA. And even in related transplants also, when we look at the donor and the recipient, we have a lot of diabetics in India, so it becomes difficult because a lot of the family members are diabetics, and we have lately started using these diabetic donors also for recipients, close relatives. So when we look at that, there is a transplant law in the country that we cannot do any transplants other than between siblings, parents to children, children to parents, and spouses. So when you look at the epitope mismatch, I have two questions. One, do we have long-term data to say the efficacy or the effectiveness of the epitope matching on the survival and reduction in immunosuppressive therapy? Number one, in a country like India, we are a developing country, is it possible to apply all these techniques? I have a very good friend in CMC Hospital, Vellore, Dr. Dolly Daniel, who does excellent epitope matching also. So I'm just wondering, these two questions I have for you.
Thank you. That absolutely very, very good question. So I want to answer your first two questions and then go back to this statement about that German meeting. Excuse me. So the first question, the first point is that it's hard to apply this concept. We do not apply this concept in cadaveric organ transplantation because, of course, you don't happen to have 200 offers from which you can choose what you want. So it's to this day, this is more something you apply to living donation, right? So the best approach for this is for this concept is to give longevity to the graft, right? So perhaps the approach is for an unsensitized patient that is young, that can receive a young organ that you want to last more than. Now, the longevity, I think the longest study from the Nickerson group is the one that I will mention for your question number one, where they studied 15 years post-transplant. And actually that cohort was a non-compliant cohort. So there were patients that did not take their medication. And it was observed that even when the tacrotru level was down to 2, patient with low risk, which was less than 11 at the RNDQ, actually they did not develop de novo DSA nor antibody-mediated rejection. So what we need to do now is to prove this concept prospectively, right? Because that was done as a retrospective cohort in a group of people that were non-compliant. That's the way you can see how the immune system reacts to non-self. Now we want to prove it prospectively. And the idea is first to prove that actually these engineered transplants will perform the same way. And the second is to, once we prove that they perform at least the same, but of course the expectation is better in terms of long-term survival, is that of decreasing the immune suppression eventually. That was your second question.
Sir,
Was about
we can conclude.
the molecular mechanism.
I think.
Okay.
Just
And then-
what is the impact of this in your observation or in the long term on the graft survival and reduction in immunosuppressive therapy?
Yeah, the one paper that I want to mention is still the one of Nicholson. I mean, it's been shown that even without immunosuppression, even without TACRO-2 levels less than 2, the patient did not develop de novo DSA up to 15 years. So if you are low eplet mismatch, and of course if you're zero eplet mismatch, that will explain just by default you're matched at the RNDQ. So there is no immunological response there. But if you're low eplet mismatch up to no more than 11, you will not form de novo DSA, and that's the long-term approach. Now, for your first question about the meeting in Germany, the eplet mismatch has not the intent, or the molecular mismatch is not the intent of replacing the common logic that we apply to kidney transplantation. So the need to transplant cannot be put aside with the hope to finding a better organ. Giving a young patient an organ that is very old or is not a quality organ just because it's low eplet mismatch, of course, will offset the benefit of molecular mismatch. So things needs to be still considered, just like we always done, and then apply the molecular mismatch.
Sir, we'll be closing this session.
Thank
for
you very
want of
much.
time to start the next session. So with that spectacular talk, we'll move on to the next session.